Good evening, everyone. So next we are going to start with the surgical sessions. So the topic for the first session is laparoscopic vaginoplasty in male to female gender affirmation surgery, 4 years of experience. The session will be taken over by Dr. Umang Kathori. He is the co-founder and director of the Hair and Shape Clinic, Mumbai. Dr. Umang Kathori and Dr. Nitin Ghag have pioneered peritoneal pull through vaginoplasty and have successfully developed a technique to reconstruct the vagina. Dr. Kathori and Dr. Ghag have catered to individuals all across the globe for PPV, and they are trying to put Mumbai on the global map of gender affirmative surgeries. So I request Dr. Umang Kathori to kindly take over the session. Sir, please.
Thank you. Thank you.
Thank you.
There's one correction that I'm going to speak upon the laparoscopic pull through vaginoplasty, inception, present and future. And that topic, 4 years experience, has been going to be taken care by Dr. Nitin Ghag. Thank you. One disclaimer that this surgical session is going to have lots of video, the surgical photograph, blood, and the body tissue. Those who are not comfortable with these pictorial presentations may kind of restrain to see the presentation. And kindly avoid photography and the videography of the presentation, because some of the patients have granted us the permission only for the medical education. Thank you very much. That's perfectly fine. That's perfectly fine. Perfect. Thank you. So BTS, or behind the scene of laparoscopic peritoneal pull through vaginoplasty. Hello. Yeah. So in 2017, we were being approached by individuals having gender dysphoria. I would like to use individual rather than clients. It's individuals suffering from gender dysphoria for the options other than penile inversion and intestine vaginoplasty. On questioning and understanding their needs, we repeatedly we started doing our own research that what tissue we can use to come out of this need of the patient, which is mainly repeated dilation, painful coitus, and optimal lubrication. We found peritoneum has been used for vaginoplasty in cis females since many decades. We started getting more inclined and interested in peritoneum as it was looking very promising option for GRS vaginoplasty. We found mainly articles on GRH, on MRK syndrome and vaginoplasty in cis women on our review of literature. There was no article or case study on GRS vaginoplasty technique then in 2017, though 2 articles did mention peritoneum as one of the options for vaginoplasty. We did some more research, we gathered some more information and started understanding the technique of laparoscopic Davidoff technique, Luhau 1 and 2 technique, the problems associated with those techniques. We found peritoneal tissue can be a very good reconstruction option to vaginal mucosa. Few articles mention the change in the epithelium and the pH after doing the vaginoplasty using the peritoneum. Few mention the long-term outcome of the sexual satisfaction. Now we were more curious as we were searching for a tissue which is abundant in nature, self-lubricating, donor side is hidden, heals by mucosylation, and we were versed with the anatomy and physiology of the tissue since our general surgical days. After gathering as much information as we could, we started developing our algorithms how to use peritoneum in a fully developed android pelvis as contrast to the cis pelvis in MRK syndrome, and what possible things which we can encounter. After this, we started doing literature review in pedicled peritoneal flap harvest and how difficult would be the dissection and what expected complication we can face, which is long-term and short-term. We analyzed and kept plan B as a free peritoneal graft after assessing the complexity of the harvesting the peritoneal flap. In a plastic surgical principle, we all know that the graft may not secrete as much mucus as compared to the flap. So that was always kept as a plan B. We met a gynecologist, Dr. Praveen Mhatre sir, who has extensive research and literature in cis vaginoplasty using peritoneum. His article have good details on peritoneal tissue, harvesting, and how it changes its mucosa over the period of time. He also has some of the articles in which he has taken the biopsy and showed the change in the mucosa from the mesothelium to stratified squamous epithelium over the period of time. Now we started tabulating the difference of using the peritoneum as a vaginoplasty organ in a cis woman in a MRKate syndrome and what we are going to use as a GRS technique. In a cis woman, the patients are normally amenorrhea or primary amenorrhea patients, so their presenting age is 13 to 15 years. The pelvis is not fully developed. The distance of deepest part of pouch of Douglas to the introit is 2 to 4 centimeter. Only the pushing method is enough for the reconstruction, and native ovarian hormone and rudimentary glands are there to support the mucosalization. While what we were planning to do was in an adult pelvis, android fully developed pelvis. Of course, the distance is more from the pouch of Douglas to the introitus. How to elevate flap is also, we have to elevate the flap, otherwise pushing method is not sufficient for this reconstruction, and external hormone support is present only in the form of estrogen and progesterone. Going back to the principles of plastic surgeries, like with like replacement and with minimum donor side morbidity, we started making our algorithms that what we want to achieve in a vaginoplasty and what are the things which we have to reconstruct this. So cavity in a cis vagina, yes, cavity can be created. The pelvic structure, at present we cannot change the pelvic structure from the gynecoid to android to gynecoid. The lie of vagina, yes, we can keep the lie of vagina which is going upwards and in center. Adventitia and musculature of vagina, at present we cannot reconstruct that. However, when the intestine is being used, it does have the adventitia and the musculature. The mucosal lining with the optimal lubrication, the options we have is urethra flap, intestine mucosa, and the peritoneum. Orgasmic sensation and clitoris, the sensate glands penis flap is always there, and we can reconstruct this. It's been being done since many decades. For the labia reconstruction, we have penile and scrotal tissue. So now we have the groundwork, or we can have the raw material with us for this reconstruction. Considering all this aspect, we started the research for an advanced laparoscopic team, because they were the hero for this surgery, because they have to elevate the flap in a particular manner so that we can reconstruct this. We made multiple meetings with them and did a virtual surgery or a fake surgery or mock surgery, step by step with multiple meetings. Finally, in June 2018, after 7 months of groundwork, we did our first case, followed by another case in 15 days of gap. Patients were informed about the complexity of the surgery, also made part of the discussion with both operating team, which is plastic and the laparoscopic, and the informed consent was taken. Since then, we have performed 48 surgeries till August 2022, considering the 2 pandemic years where the travel was restricted. We have catered patients all across the globe with different ethnicity and age group. The procedural details will be taken in detail by Dr. Nitin Ghag, but I'm going to just touch the main point, which is the bowel preparation to be done a day prior to the surgery, DVT prophylaxis, pressure point cushioning, GI antibiotic for 7 days. On the surgical day, there are 3 main steps: disassembly of the structures, cavity creation and reconstruction. In our practice, we create a neo-vagina using urethral flap and the peritoneal flap. These are both secretory mucosa to allow good lubrication. The basic steps of vaginoplasty were followed, like high orchiectomy, dismantling of the penile tissue, corpora cavernosum dissection or erectile tissue removal, make glands penis to a clitoral or a clitoroplasty, the labiaplasty. This is one video where you can see the laparoscopic view where the glass dilator is inside the vagina, and the perineal view where we are pushing the glass dilator inside. And that's a kind of cavity which we can create with a peritoneal pull through vaginoplasty. There's a 15 centimeter ruler. That's 15 plus 4. There's somewhere 7-inch depth, central midline. The patient goes to the ICU for the overnight monitoring, and they start walking or ambulating from the day 2 of the surgery. This is very important for the early recovery. This is another video, short video, which will show you on the day 14 how the tissue is being healing. There is some operative edema, and there's the medium to small size of glass dilator. The tissue is still healing, but that's the kind of depth we achieve by this procedure. Once my patient or our patient goes to their native home or their home, they start sharing us the photograph on the request on the digital platform. That could be email or WhatsApp. This video specifically shows the vaginoscopy view in which we could assess the good neovascularization. In this particular patient came after 10 months for some other intervention. Those are the blood vessels which grew, which are there now in the vagina. So that's the beauty of what we feel in peritoneum pull through vaginoplasty, that it can create the pink internal mucosa with a natural rugosity as cis vagina with minimum donor side morbidity. Those who are not well versed with this, even the cis vagina on the scopy, it almost looks like this. We got a chance to do a laparoscopy in a PPV patient after 14 months, and we could assess the donor side was completely healed. In this particular patient, it was a prolapse of the vault of vagina, and after this patient, we started doing the sacropexy of the vault of vagina. But we could see the donor side from where we had harvested the peritoneum was completely healed. There's a stitch which a laparoscopy surgeon takes to hitch the vault of neovagina to the bone, to the tailbone, or a sacrum. Now, some important information on PPV. The average operating time is 11 hours. The patient gets shifted to the ICU for overnight monitoring. Then the patient gets shifted to the room the next day. The vaginal stent and the catheter stays for 4 to 7 days respectively. The patient takes the liquid diet on day 2 and starts mobilization. The discharge is mainly on day 7 when we take the catheter out, take the vaginal stent out, do some thorough washing, and start the patient on the dilatation, which is 15 to 20 times per time, 3 to 4 times for 3 months. What complication we faced was, in initial days, we saw a lot of labia adhesions, tissue necrosis and sloughing on the peripheral or the suture lines, hematoma in 3 patients, a loss of vaginal cavity in 1 patient who was having HIV positive or seropositivity, rectal injury in 1 patient. On day 9 it was encountered. Well, the patient started self-dilating. The laparoscopic ureter injury, laparoscopic urinary bladder injury, nerve praxia, and the loss of internal depth. After doing some more refinement of the technique, now we are doing single scar vaginoplasty or a no scar vaginoplasty to negate the need of the secondary labiaplasty. Relative contraindication for this is basically the high BMI, the chronic smoker, in chronic medical illnesses or medications. We do operate on patients with HBsAg positive and HIV positive patients, or patients with the other morbidity, but in them the rate of complication is on the higher side. These are the initial pictures of our cases. You can see the suture line is there, is still healing. One problem which we face, the peritoneum has a lot of secretory mucosa. There are lots of sloughing. The peritoneal tissue or a mucosa digests the absorbable stitch sometimes, so the gapping was there. Successively, we started developing a technique where there is a no scar or single scar in the mons pubis area, which is hidden with the growth over there with the pubic hair. And the last picture you can see, there's a no scar, or all the scars are in the fold of the labia minora. This is the end point of PPV. This is what we wanted to achieve when we started doing this. There should be no telltale sign of any reconstruction. There's around 2.5 months post-op picture where you can see the scars on the abdomen of laparoscopy and the vagina below, without any perineal scars. So that's the end point. What we achieved in these 4 years is the pink colored mucosal opening of vagina, 3-dimensional labias, minimum to no scars, self-lubricating mucosa, 5 to 8 inches of deep cavity with natural looking rugosity on vaginoscopy, central lie of vagina, abdominal scars of only the port insertion, and minimum donor side morbidity. No telltale sign of GRS vaginoplasty. Special thanks to Dr. Richi Gupta sir for his guidance on a technical point which solved many of our patients' problems thereafter, which was cutting the muscle, then splitting. By laparoscopic PPV, India accelerated its popularity amongst the other countries in world of DRS surgeries. Redo vaginoplasty is again a very big topic, but nowadays we are getting a lot of patients. Simranji yesterday talked about there are certain population which want to undergo the vaginoplasty after 10 to 15 years of penectomy. This stands a very good option for those particular individuals. We do MR vaginogram or MR study of the pelvis before attempting vaginoplasty in this particular group of patient. Limiting factors for this is lack of literature, learning curve, dedicated advanced laparoscopic team, and difficult dissection between the perineum, peritoneum, and the posterior wall of bladder. But future is, of course, bioengineering and tissue culture can be done for this particular future. I would like to mention specifically thanks to Jane Watson. Jane Watson is the third musketeer of this technique. I, Nitin, and Jane has sat in a perioperative time multiple times to refine and to modulate each and every step. Again, there is no growth without involving the population. So Jane is a trans woman, and she's a very good helping hand in PPV. Thank you very much, and it all started with the combined effort from the community and from the surgeons. Thank you very much. I hope I was in time.
Thank you, sir, for that informative session. The topic for the next session is laparoscopic peritoneal pull through vaginoplasty in male to female gender affirmation surgery. And another topic is on double incision transmastectomy, modification and refinements for better chest masculinization. The session will be taken by Dr. Nitin Vinayak Ghag. He is a plastic surgeon in Mumbai and has an experience of around 19 years in this field. Dr. Ghag practices at Craftsman Plastic Reconstruction and Cosmetic Surgery Center and Craftsmind Mental Health Care Center in Mumbai. He completed his MBBS from Shivaji University in 2003, DNB General Surgery from National Board of Examination India in 2011, and DNB Plastic Surgery from National Board of Examination India in 2016. I request you, sir, to kindly take over the session. Thank you.
Thank you for the introduction. So good afternoon, everybody. So I'm Dr. Nitin Ghag. So I will be talking about our experience, my and Umang's experience of doing lap PPV for last 4 years since 2018. So as we all know, vaginoplasty is one of the most important steps in the male to female gender affirmation, and it is used, one of the commonest technique which is used for male to female gender affirmation is penile inversion or intestinal vaginoplasty. But we had certain things in our mind. We wanted a vaginal canal which is little deeper, the diameter is little bigger, you have a longer length, the direction should be little normal, and the lubrication, self-lubricating cavity, so which can accommodate for sexual intercourse. So thinking all this in mind, we thought of laparoscopic peritoneal vaginoplasty. As we know, peritoneal vaginoplasty is done for normal cis female who has vaginal agenesis, and it is a known technique. So we thought we'll use the same technique in a trans woman. So this pedicle peritoneal flap in gender affirmation can help us to achieve whatever goals we had in mind, and it will also have a bit of minimum donor site morbidity. So we hereby started as Umang explained, and we are compiled all 4 years experience of us. So before surgery, all the individual, I must say, she underwent all the diagnosis, evaluation, and by mental health care professionals, as well as all the standard care and the guidelines of WPATH, IPATH were followed. Preoperatively, as Umang also mentioned, so it's the same thing. We stop hormone therapy 2 weeks prior to the surgery and stop smoking 2 weeks prior to the surgery, as well as we have to do ultrasound and routine pre-anesthetic checkups, and all the blood investigations are done. And all the demographics, preoperative results, preoperative dimensions of the external genitalia, the complication, the stay of the hospital, all is recorded. And 1 day prior, a bowel preparation is started. So the team of laparoscopic PPV consists of expert laparoscopic GI surgeon as well as a plastic surgeon. Now the procedure is broadly divided into two. One is a laparoscopy as well as the other one is the perineal part. So both the teams start simultaneously as they begin the procedure, and the patient is in the lithotomy position. Laparoscopic team starts elevating their peritoneum after insertion of the ports. So the plastic surgeon, we begin from the perineum area, and it is broadly, the part is divided into three. One is the perineum dismemberment, which includes a penectomy, bilateral orchiectomy, urethral reduction. Second part consists of a neo-vagina cavity creation, and the third one is the reconstruction. So these are the various incisions and modifications of the incision which we have developed over past 4 years. And I guess I should take opportunity to mention special thanks to Jane Watson, who is a British trans woman who were involved in the planning of all these techniques. And plus so it was her kind of ideas, and her inputs, valuable inputs, were taken into consideration, and what the community goes through and what difficulties they have, and her valuable inputs were taken for the planning. And this is how we developed. We used to have incision extending to the groin as we started 4 years back, and now we are just doing, as Umang said, a single incision, and now we have come up to almost no scar, or just scar which is very hidden, we hardly can see it. Now, laparoscopic peritoneum harvesting begins after making the incision initially, and below the umbilicus with the electrocautery, the peritoneum is raised by the laparoscopic team, and it starts from the cranial end to with the caudal end towards the pelvis with sharp dissection. Care is taken not to buttonhole the peritoneum. Then coming to the perineal part, so that is the penile perineum dismemberment. First is the orchiectomy. So surgery begins with the orchiectomy first. It is performed by the routine midline scrotal incision, and dissection continues towards the dartos and the hemiscrotum on each side. Then the cremastic layers are transected to reach the tunica vaginalis, and dissection continues to the external inguinal ring. Cord is transected as high as possible, and it is suture ligated, and make sure that there is no slippage. Then the penile assembly, the circumcision incision kind of is made at the distal end, and it is important to leave a distal mucosal collar of the skin attached to the glans, so that it is used for the future clitoral hood which is going to be formed. Then the incision should be deep enough to the separate dartos fascia, and the penile degloving, the dissection continues between the dartos and the buccal fascia. We have to make in the avascular plane, and you have to make sure that the skin flaps are not very thin enough, otherwise they will lose its vascularity. Now coming to the dissection of the neurovascular bundle. So the dissection of the neurovascular bundle starts right down from the tips of the corporal bodies, and which are located in the glans, and the neurovascular bundle is dissected from the remaining corporal tissues. Now here we prefer to dissect the neurovascular bundle right on the outside the dorsal aspect of the tunica albuginea. Now it is tedious, I know, and it is where it includes a high risk of injury to the dorsal nerves. But this is important because it reduces the bulkiness which is present on the top of the clitoris. So that gives it more cosmetically a better appearance. Now coming to the corporectomy, so the dissection continues proximally till the pubic symphysis, till the bifurcation of the corporal bodies. Cavernosal arteries which are supplying the muscles are kind of ligated and cut, and the corporal bodies are cut at the base of the bifurcation, and the proximal stumps of these cut ends are sutured ligated. Now, coming to the clitoroplasty, I know this is going very technical, but I'm trying to keep it as simple as possible. A W-shaped incision is made on the dorsal aspect of the glans penis, and so the balance has to be made between either a very small clitoris or a large clitoris. So it should resemble the normal clitoris. An incision is made separating the W-shaped dorsal glans and from the rest of the glans and the urethra, and the distal urethra is scored out from the glans. Now, the position of the clitoris is sutured in the midline just above the corporal bodies, and the dorsal collar of the penile skin is then folded over the clitoris to reconstruct the dorsal hood. And the lateral wings are brought together in the midline underneath the clitoris and sutured together to making a new clitoral body. Now, coming to the urethroplasty. Now, the male urethra has to be converted into the female urethra, so reduction has to be done. So this urethral dissection can begin distally and before the corporectomy, that is the removing of the muscle, and the urethra is separated from the corporal body till the bifurcation, and then the urethra is spatulated right till the required length and the distal part of the urethra, and this distal part of the urethra is flipped over and it is used to line the anterior wall of the neovagina. Now, the dorsal plate of this spatulated urethra is flipped up, which forms the transition epithelium zone between the clitoris and the urethra. And it is important to ensure that the spatulation is taken proximal enough to the urethra, so it's not pointed and is not pointed upwards when sitting down to void. This is the picture of penile dismemberment. Now, coming to the creation of the vaginal cavity. So, the standard perineal approach, the neovagina is created, which involves the dissection of the perineal muscle. We prefer dissecting the perineal muscle right from the laterally and then coming to the central tendon, and dental tendon is divided transversely. With guidance of the finger in the rectum and protecting that so we don't damage the rectal wall. So, perirectal dissection is done. We have to maintain the plane, that means we have to maintain the plane anterior to the denolvulus fascia, and intermittently the assessment has to be done with the finger in the anal canal, and then as you dissect and you go more upward superiorly, you reach the prostate, and then the blunt dissection begins behind the prostatic capsule. So, behind the prostatic capsule, we have to, as I said, blunt dissection, we do it, and then we ultimately reach the peritoneal reflection. Then the cavity is widened and made more comfortable to accommodate the vaginal dilator. Now, coming to the peritoneal laparoscopic part, the peritoneal dissection, the peritoneum is elevated, as I said, cranially, just below the umbilicus, along, and the whole anterior abdominal wall. It is elevated towards the bladder. Then it is reflected from the dome of the bladder and the posterior wall of the bladder, and laterally the dissection is limited to the medial sides of the iliacs, and the entire peritoneum is mobilized. You can see how the peritoneum is elevated. Then this perineal side, the blunt dissection continues, as I said, behind the prostatic capsule, and then you reach the pouch of Douglas. Then vaginal dilator is inserted. Then through the abdomen, through laparoscopic camera, we appreciate the insertion of this dilator, and then all the muscles in between the dilator is cut, and the opening is made in the pouch of Douglas. The muscles are cut, and the opening is made. And then all the intervening tissues are kind of widened, and we have made sure that the cavity is loose and there is no constricting bands in between. Now, once the cavity is free and created, the distal part of the spatulated urethra is pulled through the cavity, thus lining the anterior vaginal wall. And then with the sponge holder from the exterior, we hold the peritoneal free end and pull it out and get it to the exterior so that it lines the whole vaginal cavity. and it is sutured, the distal end of the peritoneal margin is sutured to the posterior fauciate skin, and anteriorly it gets sutured to the linings of the urethra. So thus you have urethral surface as well as the vaginal peritoneal surface, both secretory. Now inside, as once the peritoneum has come out, again with the purse string sutures, all the pelvic peritoneum is gathered up and sutured to create a new top of the vagina. Now coming to the third part, that is after you created the whole cavity, you have to reconstruct the whole thing. So now reconstruction of the labia majora. So the remnant of the tunica vaginalis is oversewn and sutured laterally, just creating a bulge and elevation, just like a labia majora. Labia minora is created by using a penile skin. The inner edge of the labia minora is sutured to the peritoneum. The preputial skin on the dorsal aspect below the glans or the clitoris, I must say, is sutured to the clitoral hood, and the upper part of the labia minora penile skin. The lower end of the is sutured to the posterior fauciate skin, which is just 2 centimeter lateral to the midline. This is the on-table assessment of the depth of the cavity which we achieve. This is almost around 7 to 8 inches. Coming to the post-op care, so I'll just rush through this. Just general wash is given, hemostasis is achieved, vaginal pack is inserted, T-bandage is applied, catheter is in position, DVT pump is continued for in post-op in the ICU. Patient stays in hospital for approximately 8 to 10 days. On the 5th post-operative day, the pack is removed, and if there is no abnormality and everything is okay, then on the 10th day the catheter is removed and the patient is discharged once successful voiding. Patient begins the dilatation on the first clinic visit on the 7th day to 10th day post-op. So these are the few statistics which we have gathered. So we have totally done around 48 patients underwent laparoscopic PPV, ages ranging from 24 to 57 years of age. Hospital stay was around 10 days, 1 to 2 days in ICU, 7 to 9 days in the ward. Duration of surgery was minimum 8 hours to 14 hours. Cavity length achieved was around about 6 to 8 inches. These are few of the results of PPV. This is again another patient. Here we used to use a silicone kind of a vagina labial stent, so to give a 3rd dimension elevation. This is again a patient where we are doing minimal scar technique. This is another patient. This is a single scar, and this is an on-table result. This is the same patient after 10 days and then after 1 month. This is again after 6 weeks, and this is again after 6 weeks, and this is after 3 months result of the same patient. This is after 3 months. So here you can see the clitoris, then the labias minoras you can see the peritoneum which is kind of healed. And then once you can see this is a little longer. So here you can easily put 2 fingers, and then it will show the dilatation part, almost approximately 8 inches, 7 to 8 inches of the, around 5 inches of the dilatation, the length is achieved. And if you maneuver it more with deeper and relaxing all the muscle, you get another extra 1 inch. So follow-ups, majority of our patient, almost all of our patient were from out of station, 18 followed in person, and others were contacted telephonically or through digital channels. These are the complications which we have recorded. Hematoma was recorded in 3 patients, all below the clitoris, and 1 required re-exploration. Then labia minora dehiscence was seen in almost 28 patients, 8 required labiaplasty. This was initially when we had an incision going up to the groin, so almost the majority of our patient had dehisced from the distal end, because the distal part and the tip of the penile skin used to come at the junction. so which had precarious blood supply there. Then decrease in the cavity length in 6 patients because they were not properly dilating it. Then discharge and fluid flow from the vaginal cavity was seen in almost all patients, but gradually slowly reduces over time. Then bowel injury was seen in 1 patient. This also was noted on the 9th day after surgery, as the patient was self-dilating. Then laparoscopic bladder injury was seen in 2 patients. This was intraop, and intraop it was sutured and handled. Neuropraxia because of the position was seen in 1 patient. Then laparoscopic ureteric injury was again intraop noted in 1 patient, but later on it had to undergo replantation by urologist. Then there was a partial peritoneal flap loss was seen in 1 patient who was seropositive, HIV positive, and who again underwent a redo where we used a free peritoneal graft. So conclusion, coming to peritoneal pull through vaginoplasty offers an outcomes in transgender women as an option that will give a self-lubricating with adequate diameter, length and appropriate direction with insignificant scarring coming with the modified techniques and fewer complications with a high degree of patient satisfaction. Thus PPV can help us to achieve anatomically and physiologically as normal as a cis vagina. Thank you.
Continue. We've opened the floor for discussion.
Oh, and I will do it. No water. I guess coming to the second topic now, that is double incision transmastectomy and its modification and refinement for a better chest masculinization. So top surgery, one of the commonest and the procedure and the first procedure done by patients undergoing transition, and it is seen to have improved one's mental health drastically. So the choice of reconstruction depends upon various things. One is the age, then the size of the breast, the ptosis and the quality of the skin. Smaller breast, as we all know, there is a semicircular or transareolar technique. Advantages is a small concealed scar, but this also technique has some complication, may have hematoma, seroma, and sometimes because of little bit of ptosis, you might get some periareolar crumpling of the skin, and which may require some revision at a later date. Larger breast, as we all know, we go ahead and do a double incision mastectomy with a free nipple graft. This is a good technique which gives a nice exposure. Optimization of the nipple complex position can be achieved. Low revision rate, high patient satisfaction because you get a good flatness of the chest. But it comes with a heavier scar burden. It will be a long, lengthy scar which is going and extending into the lateral chest wall. You may have retained skin folds which are there in the lateral chest wall, or they retain breast tissue and the fat, and this may require further revision. These are few of the unpleasant outcomes of a double incision mastectomy which I have picked up from the internet. One is the aesthetically unpleasant long scar, then improper placement of the incision and the incision joining in the midline, which kind of gives a very unnatural look. Then the scar extending into the lateral chest wall. Then the retained skin folds and the fat bulges in the lateral chest wall. Then malalignment of the nipple. Nipple is this thing fixed in a very, not in a one plane, in a up and down direction, this thing. As well as there are some retained fat bulges creating some elevations. Then there is nipple graft loss and the malposition of the nipple. So how do we refine and modify these techniques to get a better aesthesis? So the first, what are the goals of masculinization? And the bottom line of the whole thing is we have to get a natural looking masculine chest. So how do we achieve this? One is, of course, after excision of the breast tissue. Depending on the volume of the breast, the ptosis and the elasticity of the skin, you'll require a lot of skin reduction and lot of excision of the skin so that it creates a very taut male and aesthetic male chest. Placement of the nipple areolar complex should be placed in the position like the normal males, and elimination of the inframammary fold should be done. Then there is minimization of the anterolateral chest wall as well as the skin folds which is there in the lateral chest wall, and of course the revision rate should be less. So coming to the markings, so I'll just rush through this. Superior incision is marked straight across the breast, 1 centimeter above the IMC. Lower incision is marked 1 centimeter above the IMC. The marking on the lateral side extends, we angulate the incision laterally, which goes about 0.5 to 1 centimeter behind the lateral border of pectoralis major muscle, and in medially we angle it up upwards and just keep an island of 2 centimeter skin in between. But this sometimes may not be possible because in a heavy breasted individuals we might find it difficult. So sometimes there are techniques which shows an inverted V pattern or gull wing pattern, but still we do not kind of use that technique because because joining the two incisions together in the midline gives a very unnatural look. So we have done little modification for that. Now, keeping in mind is the masculine chest. This is the target. This is what we want to achieve. So there are certain important points you have to be noted when we are doing in masculine chest. The upper part of the pectoralis major muscle is little bulkier than the lower part. So it is divided into upper and the lower parts. And there is a triangular area of depression on the lateral side of the sides of the pectoralis major muscle. This is called as the negative space. So you do deep liposuction in the upper part, you do aggressive liposuction on the lateral part, as well as you do aggressive liposuction in the superficial and the deep planes in the IMC area. Now the surgery begins with the liposuction, and after giving a thorough lipoinfiltration with the puncture holes, the liposuction is done. Then the inferior flap is raised. It is done as routine double incision mastectomy, the same way you do it. But yes, you have to disrupt the IMC, which we have done by liposuction as well as surgically also. Then superior flap, again superior incision is made as per the markings, and this is done in the routine way as double incision mastectomy is done. Now, before you excise the whole breast tissue, you harvest the nipple areolar complex. So we make it reduced to around 2.2 centimeter, and we harvest the nipple areolar complex and then keep it in the wet saline gauze. Now, once the breast is excised, then you close the incision. We just tailor tack the incision with staples. So this creates a dog ears on the medial side as well as the lateral side. And then when the lateral side, you upturn the incision. So what we do is when there is a dog ear which is there on the lateral side, we kind of pull the tip of the skin and direct it to the upper part of the shoulder, catch the tip of the dog ear and direct it to the upper part of the opposite shoulder. And this kind of recruits the loose skin from the lateral side of the chest more upward. And because you have done liposuction also, there's a hollowness is already created and the skin gets recruited, and that excess part of the triangle is excised. And so automatically the incision goes just behind the lateral border of your pectoralis major muscle. So almost 0.5 to 1 centimeter behind the lateral border. And then medially, again, as I said, it might be difficult, so, but still we don't join the incision. We continue making the incision on the medial side. We dig the incision upwards. We keeping a 2 centimeter skin island in between, and there we again do a lot of aggressive liposuction in between the skin island, as well as we remove the fat also surgically, so that there is less fat tissue there, and it's only the dermis. There might be initial crumpling seen in the skin island intervening in between the two, but eventually we see that over a period of time with scar massages and everything, the whole flatness is created there. So closure, the incision is as usual, it's closed initially with the staplers. Hemostasis is achieved. You put suction drains applied. Superior flap here we hitch with the anterior chest wall, and then monofilament sutures is used and sutured in layers. Then I also put a simple interruptus sutures on top of this monofilament running sutures, just an added protection and added this thing because it's a long length of sutures, so there are chances of adhesion to prevent that, so we just put simple sutures on top of that. Now coming to the position of the nipple complex. So nipple complex, as I said, is marked about 2.5 centimeter from the junction of the lateral and the inferior border of the muscle, and 1 centimeter above the IMC. We mark it a little more oblong to give it a very natural look, and then we deepithelize the whole skin. Then the nipple is placed on that, and after reducing the thickness as well as removing a lot of dermis as well as lot of tissues behind the nipple complex, so that it reduces the projection, and then we suture it back to this deepithelized area with suture it with non-absorbable sutures in an Army Navy fashion, and then we put a tie-over dressing on top of it. This is the crumpling of the skin which I told, but this eventually settles down at a later date. Then normal dressing is done with lot of padding over the lateral chest wall and the superior part of the chest. Then you have a long compression tapes are applied on top of it, and then binder is applied on top of an added compression. Drains are left and they are removed once the discharge is less than 30 ml over 2 consecutive days. These are few of the results. This is one patient where though the lot of breast little ptosis is there, as well as the elasticity of the skin is not good. So though even the size of the breast may be little smaller, but the elasticity becomes very poor because the individuals tend to use lot of binder, chest binder. So because of the chest binder and continuous compression, the elasticity of the skin becomes very poor. So the contraction of the skin, so normally in a smaller breast, where like in a male patient where the gynecomastia patient the skin shrinks, this doesn't happen in this individual. So the thing is, the double incision becomes a better choice to get the proper flatness of the chest. So here is the first post-op week. Then again another view, so you can see this incision which is going just behind the posterior lateral border of the pectoralis major muscle. This is after 1 month after surgery. This is after 1 year, 3 months after surgery. So once he resumed his normal lifestyle, doing gymming, and you can see the flatness as well as the scars. This is again almost after 1 year, 9 months. You can see this is what the point. This is the incision and how it is just behind the lateral border of the pectoralis major muscle. This is fallen into the pectoralis muscle shadow. This is another view again after 1 year, 9 months. This is a second case where this is after 10 days post-op. This is what I was seeing, the skin crumpling, which normally is apparent in the initial days. Then this is after 10 days, another view. This is after 4 months. There is little hypertrophy of the scar, but then we give little scar therapy, massages, applying of silicone gel sheets. This seeing patient resumed his normal gymming and doing all his workout. This is him again after 1 year, 10 months. Of course, I told him and he sent me a black and white picture. Then again I called him, then he sent me this. So this is his chest. You can see it's a lovely, of course his hard work goes in gymming. His lovely pectoralis muscle definition, and the scar is just going behind it, and this on this side also. Nippericular complex also is good in position, looks good. Here this skin crumpling has nicely settled down. There's an almost flatness achieved. This is the same thing, another view. This is another third patient. Here again, initially, this is my initial patients where this you can say I used to go a little straight here, but now I started addressing. This is my initial first, second patients. But of course, to show you this, because it's the amount of the breast tissue, it's so huge and almost coming from the midline. So here we again left a gap, and as I said, liposuction and removing the fat tissues from center. So the crumpling and everything kind of settled off. So the results in this, patients generally scar stretching happens in these patients, especially in the lateral chest wall where the upturning is there, and that little scar stretching is generally there because normally a moving hand doing gymming, so that a lot of traction as forces are there on that incision. The entire, if there is a stretching of the scarring, then the option of scar revision can be given, as well as, or if there is no much, you can do a laser treatment on that to reduce and minimize the scar look. And of course there is a scar over the circular nippericular complex area also, so sometimes the definition of it is not very prominent, so in that we can also add up medical tattooing to create a more defined nippericular complex if required. Yeah, all these options were given to my patients, but none of them wanted. They were very happy with the flatness they had got and the look of the masculine chest, and they were confident and happy. So conclusion, coming through, the double incision mastectomy with the free nipple graft in a large ptotic breast with poor skin elasticity has its own issues of long lengthy scars and retained lateral skin fold. But if you do certain modifications, certain refinements of your technique, we can get a good aesthetic masculine chest. Thank you.
Thank you, sir. The floor is now open for discussion. Please give the mic at the back. I think, sir, you can speak if you can hear it. Yes. After this, right? Yeah.
The question is very simple. I kind of understand all of this mostly because I'm a trans man. But what is the motivation behind helping the transgender communities? What is more important for me to understand? Just that.
Yeah, can you hear me? See, what I feel is, the transgender community, there are certain lacunae, especially concerned with the surgical aspect, the surgical transition. Lot of things, lot of incidences have happened over the past where we have seen patients which have not got proper standard of care or whatever kind of a treatment. I guess the incident which happened in Nalgonda district in Andhra, where some quacks had operated on the patient and the patient succumbed. So there is a lot of lacunas in this. And plus me, I always wanted to help this community. We were trained during my training in the transgender surgeries and everything, and working in a medical college in a municipal background in Mumbai, where I started that transgender surgeries, because there was a lot of demands, a lot of patients used to come to me. The first patient I remember was a trans man who was on hormone therapy, everything he was taking, but he was referred because he went to gynecology department for hysterectomy. And then the Maushis and the Ayaba is there, ki, why are you entering here, you are not here, because they identified him as a male. And then fortunately one of the residents knew that I do the surgery, so she referred him to me. And that's how the process started. And then I said, let me help you. And he told, this is what we are having, a routine issues, and this is always a problem. And I said, there is definitely a need to help them and need to help the community. So that's how the whole thing started. So that's how, then after once he was operated, he was happy, and then, you know, that whole thing, journey just started off, and all the patients started flowing in and everything, and started doing all the work. And it's more, I feel the surgery is very challenging also, because we have to do something with whatever resources we have available. We have to create something and give it so that it resembles what you are looking for.
Thank you. From a surgical point now, okay, since I've done my surgery, so just coming from that side. So there are surgeons that I am aware about, and a lot of our applicants from the charity trust that I run apply for surgery grants have found a concern that there is no certain surety, right, about the surgeries. Of course, I understand, depending upon the body, the structure, and all of this comes to it. But is there any protocol or guidelines right now that is followed amongst the plastic surgeons throughout India or otherwise, which can actually make sure that the outcome that a person goes through as a transgender person is not traumatizing? Because if there are still suicidal cases post the surgery, I don't think we have reached the mark yet, right? So is there somewhere where if we have a problem with the surgical process, if we can claim to the Ministry of Healthcare or somewhere where we can raise our voice? Because there are people on catheters for months after a surgery, and I have come across them personally. So this is not talking out of social media posts, this is talking about personal experiences. So that is a concern for me, right? Because right now I have no place to refer when our applicants, as I said yesterday in one of our seminar, that I have personally no place to refer and count on the doctor and say, yes, this is where you go. I can't say it. So is there some way their surgeries and the outcomes can be assured?
I'll take that question.
Yes, please.
So the idea is, Mr. Mann, that since yesterday, what I'm understanding that the lack of bridge is the most important thing which we are facing right now. Yesterday, when we attended the session, I think I would have appreciated if this session would have been attended by a lot more audience, those who want to get benefit out of the surgical thing. They would have understood in a better manner, first. Secondly, as a plastic surgeon, as an aesthetic surgeon, we are very innovative surgeon. Even in a cisgender population, we have to customize our procedure, be it a liposuction, be it tummy tuck, be it gynecomastia, be it any other surgery, be it just a facial rejuvenation. So there is no standard protocol. Of course, we follow WPATH guidelines before doing this or before doing any surgical intervention. Blaming just to put that mark, surgical mark, and then there is a suicidal rate. There's a lot of social aspect is also important. We never say this surgery is the end point. The social support, the bridging which I'm talking about, that's lacking, and that's most important. Surgery, we never say it's an end point of transition. Transition is an ongoing, lifelong process. But still, lack of awareness, lack of that bridging between the community and the appropriate surgeon is the most important aspect which I feel.
I agree. The only thing that bothers me is, for example, he's your friend and a very good vaginoplasty surgeon, right? So instead of, because the patient has come to you, why can't we create a safer place where you know this guy has the expertise to run that particular surgery? So to mention it out, to refer it out to him, because we do it, right? In medical practices, an endocrinologist would refer a surgeon or something like that. So why can't we go ahead and have something, a rapport around the doctors and surgeons itself, which is not competitive?
It's because, that's what I'm telling you, it's there, already there. If the patient comes to me, transplant for the top surgery, I refer him to Nitin. Because my expertise is more in vaginoplasty and I'm developing that as my expertise.
Yes.
So it is there, it's just because you are not aware of that, doesn't mean it doesn't exist.
Yes, Sanjay sir wants to input, I like it.
Thank you, Man. Let me assure you that all these things that you have said, we are already working on it. We are creating an ecosystem where we are talking to each other. Something which was not done 3 to 4 years back. We are getting a consensus, and we already have the Indian standards of care, which was not only to say that these are Indian guidelines, it was also to get those professionals together to write them. You know, and when you indulge in an academic activity across the country, you know, then those small barriers that you have between procedures, between experts, they diminish. We are on the path. I request you to give us a little time, because this cannot happen overnight. So we cannot have a center which ticks all boxes. It will take time, but we are on the path of that. And we are way ahead of lot of countries. A lot of countries.
Yes.
Right?
Yes.
I also understand that there is impatience. You know, because if I take 5 years for these things to develop, then what about me who's standing at your gate, sir? And that is why this question. And that is why I turn to you to, say that, look, we have heard, we are trying, we are going to build, right? When we look at it like this, probably we'll be able to turn back to you and say, I hear you. I am trying and I am looking at support from you so that we have this hall full of people who really will get affected by what is happening, you know, and they are able to give us feedback that, look, this is what we want more. So today, if let's say Umang does one procedure, right, then tomorrow when Umang does a similar procedure, he betters it, right? That is what will happen. And the medical science is not an exact science, right?
I think the community is not here present today because they're scared.
But we will.
The doctors will disagree on their surgeries.
No.
They're really scared.
Not at all. Not at all. See, why we are here? Why have these surgeons left their practices and travelled? And people have travelled across cities to come here. Is to give you that reassurance that, look, we are not closing ourselves in silos. We have put this section, the surgical session last. And you would wonder that why is it not important? No, it is important because when I get that person, he first talks about surgery. But I said, please, let's listen to surgery after you have listened to mental health.
Right.
And before you even start mental health, what about social support? Let's first get that. Yes. Let's get the government viewpoint. And yes, this is where we are, but this is not the end point. Because I'm going to walk out with those scars into a society which needs to accept me. And that is why even if I have one cis hetero person who's listening to us, yes, me included, who's thinking about how to make this, how to give space. then we have achieved what we have set out to do.
Sanjay sir, thank you. It's
I
because of WPAD, now I would say, it's because of WPAD and ATHI, I still hold the trust that the Indian economy will consider that this is a booming market. Transgender is not just helping them to stop being empathetic, okay? We are asking help because you are the professionals. At the same time, this is a booming market that is rightly available for you, and that's the transgender community, with a lot of pride. So, sir, I trust in you, and I hope that the surgical process do not need any more recorrections anymore. Thank you.
I would like to answer the first question. Yes. The motivation towards the community was to come here, attend yesterday's session, to sit, to understand the demand. The motivation was to create vaginoplasty, which was not there. We did our own research. That was the motivation. If not then,
thank you for your allyship, because I know there are thousands of plastic surgeons, but you still coming out here and showing the support means a lot. So thank you for the allyship. I respect that. I'm not always complaining. Thank you, thank you.
No, as Dr. Sanjay was telling, this is an evolving field. We are just trying to organize centers of excellence for training our youngsters to do a perfect job, maybe where you can see the results and outcomes soon. Maybe the next session. Yeah.
Thank you. I would like to invite Dr. Sanjay to felicitate the speakers, Dr. Umang and Dr. Nitin.